Okay. Today is Friday, March 29th, 2019. This is Hannah Crawford for the Global Polio Eradication Initiative History Project with Dr. John K. Andrus. We're in the United States Centers for Disease Control and Prevention in Atlanta, Georgia, in the broadcast department. This is our second interview session focusing on polio eradication in the Southeast Asia region of the WHO. Thanks for being here. You made extra time to do this second session, so I really appreciate you coming.
Thank you for inviting me.
Of course. And so before we begin, do I have your consent to ask you questions and record your responses?
Yes.
Okay, great. So I thought I'd do a little bit of follow-up from the first session just to kind of bring us up to speed going into number 2. So in a list form, in session 1, we covered your time at PAHO, largely focusing on 3 different tasks or areas. So AFP surveillance, coordinating the global or the polio laboratory network in the Americas to kind of merge epidemiologists and virologists into a team. And you also put together criteria for polio certification or certification of the world being polio-free or the region being polio-free. You worked with Frederick C. Robbins on that. We talked a bit about leadership style, and then we talked a little bit about India, leading in India. Talked a little bit about the Surat outbreak of suspected plague in 1994, and Danita's interest in creating surveillance, the National Polio Surveillance Project. We talked about routine immunizations and kind of ended with challenges moving forward. So I guess to open, today we'll talk mainly about 1993 to 2000, your time in the Southeast Asia region of the WHO. So to begin, would you mind introducing us to the region and sharing a few of your earliest memories?
Well, thank you, Hannah. As you asked that question, I immediately went to the messaging that was consistently presented globally before leaving PAHO, and that was that India had half the world's cases. So when I was approached, still working for Cyril de Quadros on the PAHO team, I was approached to consider to go to India with the experience I had in the Pan American Health Organization. And as the date and things finalized and the agreement was there, and I was about to embark, I started getting anxious about a new job and this daunting thought, gosh, I'm going into a situation where half the world's cases are being reported. So when I landed, and at that time it was the old Indira Gandhi Airport with my family in New Delhi. Before landing, we took a holiday in Provence, France, and it was a wonderful holiday, very relaxing, getting recharged between coming off the PAHO experience and getting ready for India. So with that was, excited, and then walked out the door of the Indira Gandhi Airport, and there were a couple of crawlers right there almost immediately. And so all that sort of healthy anxiety about what I was getting into immediately struck home with the visualization of these crawlers. And I started, fortunately, I took it positively. I go, gosh, here's an opportunity to prevent that. So anyway, those were my first thoughts. In those days, coming out of the airport, you were surrounded with people, many of whom were beggars or trying to give you a ride in their taxi, and the noise and the colors and the smells. And I remember looking at my wife at the time, Alice, and she was like looking at a deer in headlights. And so anyway, those were my initial, immediate impressions on arriving to India.
Could you talk about what it means to be a crawler, what it means to be paralyzed?
Yeah, so as the Peace Corps volunteer in Malawi, as a district medical officer running a hospital, both curative and preventive medicine services, I got exposed to what was called Malawi Against Polio, MAP. And it was a program where the Ministry of Health sent a van that was equipped with calibers and other orthopedic supplies and equipment and trained personnel that made regular visits throughout the country to the district medical officer hospitals. And we would have the patients ready to be treated and helped with these devices. So I got exposed to, at that time, the debility that polio presents and the disfiguration, the contractures of the lower extremities, and how you can take a child that with severe contractures cannot walk, so what we call a crawler, to one that if you do a tendon release, you could help them with the caliber and with certain braces, you could then, the child could ambulate. So but in India at the time, there were crawlers everywhere, just about on every corner. So again, it was a visual of the extent of the problem, particularly people living in poverty, what the challenges, just getting around. They had a little skateboard often where they could then, with these contractures, at least sit on the skateboard and be mobile using their hands. So that's the term crawler, in the sense that they cannot walk, they have to crawl. And if they have this skateboard, simple device, they can get around. But ultimately, you'd like to be sure that they are channeled into treatment services, rehab services that can provide some of the tendon release surgeries and other devices that will help them be mobile.
What about the social dimension to it? Thinking about kind of the disability rights movement in the United States, and perceptions of people with paralysis.
Yeah, certainly there's a stigma, and in those days, in the early 90s, there was a stigma. The polio victims were, most of them, by far the majority of them, were people of poverty. So with that comes a stigma, because in India in particular, you have a caste system. And so many of those barriers had to be tackled. There was a rehab hospital in India, probably at the time one of the biggest in the world, and I have several photographs showing children being followed. One of my favorite photographs, though, that we actually used on a cover of a field guide were two children, perhaps 6 or 7 years of age, with their obvious calibers, and they're both standing up, and they're both hugging each other, and they're both smiling. And that sort of message, despite all this, I can embrace life, and this is my dear friend, as only children can do. So it was, yeah.
What was the landscape of the polio program like when you arrived?
Ooh.
What was going on?
So when you asked that question, I immediately sort of went back to the first time I visited Kaushik Banerjee, who was the director of the Immunization program. For those of you that have been to New Delhi, there is sort of a mall area, much like Washington, D.C., where there's Parliament, there are these very large buildings and grandeur of the central government, like our capital. And it's beautiful. There's India Gate there. There's the president's, it's either the prime minister or the president's palace. There's Parliament. And then lining that area are the various ministries, and these ministries are huge. Well, Nirman Bhawan was the Ministry of Health, and you go through security, and I somehow made my way up to his office, and I'll never forget walking in. It was like a closet, and half of it, there was a little curtain. The secretary sat there. It was basically 3 people. So the secretary sat there, answered the phone, and then there was a curtain, and then there was Kaushik's desk, and he had all these piles of paper with paperweights of various designs, and it could be a Ganesh, it could be one of those glass bubbles that when you shake the snow, and all that was holding the papers down because the window was open. It was so hot. The wind would come in, and if he didn't have a paperweight, the papers would fly everywhere. And then behind him was this young chap, probably in his early 20s, who sat at a computer, and all he did was enter data. He was managing the national immunization database for a country of 1 billion people. So this was India. Now, that's your picture. And the fan is going like this, and there's dust. But if you went to Dhaka, Bangladesh, there was this beautiful building, and it was the EPI building. It was 3 or 4 stories. There was a section on cold chain logistics. There was a section on epidemiology. There was, it was just this wonderfully designed building that was fit for purpose in vaccinating children. Whereas in contrast, it was, this one computer with this huge database being used to drive the program. And poor Kaushik was there, managing. So that's how I met him, and I was immediately attracted to his work ethic, his character to do the right thing. And I decided, if I'm going to make a difference in India, Kaushik was critical. And I knew I had to become dear friends and a colleague. That would have happened regardless, but I was certainly motivated in order to get the job done. And it was very fortunate that Kaushik had the character and other personality characteristics that reinforced our friendship that developed over the years and to this day. But that was imagine that, you're going, when you're coming from PAHO, you just said goodbye to your friends. Steve Kachi was my supervisor at the time, and you're at CDC Atlanta. And by the way, CDC Atlanta at that time were these 3-story brick buildings, and today what you see is a huge campus that's completely different. But you say goodbye, and then you land. You go, gosh, this is daunting.
How soon did you meet Kaushik?
Sorry?
How soon after arriving did you meet Kaushik?
I can't remember, but it was within the first few days, weeks. I was very intent on bringing the PAHO experience, and there in Latin America, our field officers were expected to sit in the Ministry of Health. They weren't, if they sat in the PAHO air-conditioned office, they weren't doing their job. And Cyril de Quadros used to require that they send in a monthly Venn diagram, fax him a Venn diagram of just a pie chart, not a Venn diagram, but a pie chart of the proportion of their time that they'd been at the Ministry of Health, out in the field or in meetings. And he just wanted to get a snapshot. Boom, okay, that person's doing their job. They're either in the field or they're with their ministry counterparts. And so I came with that knowing that I was going to be living in these conditions. And that's basically, Kaushik was a force of nature in the sense that he was so dedicated and worked so hard. And we spent many long hours in there trying to strategize how do we get the polio eradication strategies off the ground. And the other fortunate thing about Kaushik, he was totally committed. He had done his, in India you do a thesis when you get your doctoral degree, I believe. So as a medical doctor, he had done his thesis on polio. He had worked in a polio lab, and he had a research question that he tested and had done the work and written about it in order to get his degree. So he was quite exposed. Before being the national immunization manager, he had been the Delhi immunization manager. And Jatna Soki, who in Nirman Bhawan at the national level, director of the maternal child health program, saw a good thing. We'll probably come back to Dr. Soki, but she definitely saw a good thing and hired Kaushik to run the national immunization program.
Do you remember your first conversations with him about where you needed to be headed?
Well, basically it was a process of informing leadership, empowering leadership of Kaushik or Dr. Harshvardhan at the Delhi federal district level, much like our Washington, D.C. India has the Delhi district, and Dr. Harshvardhan was the Minister of Health of that district. You start by sharing articles, discussing the strategies. I always had 3 or 4, those were the days of the overhead. So you had these plastic sort of overhead slides, and I always carried them in my carpeta, my little fold-up briefcase. And it had the Brazil NID, an example of a large country doing a successful NID that just had an enormous impact on disease burden. And then I brought a couple of slides on surveillance, and so 3 or 4 that would help guide the discussion. So we could sit there with the graphics, and I remember doing that kind of thing with Kaushik, but in particular Dr. Harshvardhan, because here was another gentleman in a leadership position that was incredibly passionate and prideful of his country and the potential that his country had. And so when he said to me, you know, if the rest of the world can do this, why can't India? We did smallpox. So he got it, and that he in the one of the newsletters, I think it was the Indian Pediatric Journal, one of those journals, he wrote up a 3 or 4 page technical, here's a minister of health, he's a pediatrician, but he writes this technical article on the value of polio campaigns, the national immunization days, and why he's going to do that in the state of Delhi and demonstrate that it can be done. You know, Delhi is this enormous city with all these slums, and you know, so at that time, those 2 leaders in particular. Now Kaushik is handstrung. You know, what do you call it? Handstrung, or he's handcuffed by his supervisor, Dr. Soki. He can't do anything without her permission. So he can understand the strategies, he can be passionate, he can be dedicated, but it's going nowhere unless Dr. Soki takes it to her boss, the Minister of Health and Family Welfare. Whereas Dr. Harshvardhan he owns the keys to the castle of Delhi, and he's the go-to person, the buck stops there, he can do it. So it was fortunate that he did it, and when it was successful, parliamentarians, the rest of India, learned about how in Delhi this worked. At the same time, Kaushik and I are trying to convince Dr. Soki. So in those early days, when you asked me, do you recall, I remember sitting at 9, 10 o'clock at night. It could have been Friday, and you just want to get home to your family. Your 2 girls are I think 3 and 1. And she had this way of communicating. There would be these silences that would go on for 5-10 minutes. She would, I don't know if she was meditating, I don't know what was going on, but we were respectful, and we would sit there during those silences. And there were times like, oh, I wonder, would it be rude if I got up to go to the bathroom? Or, when is she going to follow up on our question? So there was that kind of dynamic that made it very, very challenging. So she tasked Kaushik. Well, first of all, she made it very clear she didn't believe that polio eradication could happen in India. So that was a huge barrier that we never overcame with her, to be frank. But she tasked us, and so I thought there was a ray of hope, to produce a field guide on the surveillance of acute flaccid paralysis. So working with Kaushik, we drafted several different versions because she always found something wrong or didn't like. And we worked weekends, and we wanted to turn it around very quickly so that India could begin reporting and make acute flaccid paralysis notifiable. And once they made that decision, that you would need the technical guidelines to follow, the case investigation form and so on. So that document, every time we came to her to present it, was those sort of dynamics of silence, what'd she think, and getting it approved. And finally, I think it was in 1994, during that time, that could have been 95, but I think it was 94, that she approved the field guide, it got published, and the AFP became notifiable. So there was that ray of hope. But with the National Immunization Day strategy, the vaccination strategies, the door was slammed shut with double locks and chains, and there was no way getting in. So, bless his heart, Kaushik did a very brave thing. He went around her and went to the secretary, the Minister of Health and Family Services. Now, there were other moving targets, with the successful immunization campaign in Delhi that Dr. Harshvardhan led. That information, that evidence was being floated and exposed. People knew about it. Parliamentarians knew about it. So there were discussions in Parliament. Rotary using their leadership, Mr. OPV vaccine. He was very proud that his name was Ipv, and he was a go-getter. He was a gentleman too. He was just a delight to work with. So these were things that were happening simultaneously. But Kaushik put his his professional job on the line. He had children. His apartment, with that level of responsibility, is just. I remember how. I just thought, wow, what a dedicated person. His apartment was very simple. It was very small. I think his children had to share a room. Anyway, you see that over and over working overseas, and it just does it does a reality check for you about how dedicated people are with little reward. So fortunately, the minister bought it, and so in '94, Dr. Harshvardhan conducted the Delhi campaign on Mahatma Gandhi's birthday, October 2nd, I believe. And all this is happening, it takes time, but by the winter of 95, 96, India conducted its first National Immunization Day. There was a sort of a challenge of global vaccine supply, so they couldn't target less than 5s. They had to target less than 3-year-olds in their first campaign. But it was an amazing social mobilization effort, and it was a celebration like Latin America. There was the poorest of people dressing up in their best clothes, and there were banners and flags and radio announcements and television. Some of that changed over time, but I remember that first one. And Dr. Harshvardhan had used that sort of social mobilization strategy too, because the thing about Dr. Harshvardhan, it's rare that you see a leader at his level, a political appointee who's technically minded and driven to stay up all night to be sure the vaccines are going to the post. I didn't know if I could. By 5 a.m. in the morning, I felt like, gosh, am I going to make it through the day? So he invited everybody to his home, and then we fanned out and went to the post to be sure. And the Rotarians were there. He had it like a 4-star general, had everything in place and managed. Amazing. I think he knew that the risk of failure, there was too much writing on it. Unless he succeeded, then, that would, if it failed, then India wouldn't go forward. One other thing that was happening at that time, I believe, on Mahatma Gandhi, on Prince Mahadal's birthday of Thailand, in November, I believe, of '94, Thailand conducted the first National Immunization Day by a country of Southeast Asia. And then in early March and April of '95, Bangladesh followed. So you had those forces that I described in India, but then you had regionally the other leadership catching hold, accelerating their strategies. There was a great momentum. The train had left the station. So Parliament and at that time the Minister of Health and Family Welfare was making this decision as all these other things were happening that helped. I think what I recall about the Bangladesh NID is clearly the dialogue in the Parliament changed. Our friends are doing it, our neighbor. How come we're not? And they would call the authorities from Nirmal Bhawan to their committees and grill them. What's going on here? How come we're not leading the way? And so I think that helped with the first NID and that sort of enthusiasm, making it a celebration of life.
You said a little earlier that NIDs were out of the question.
Yes.
Could you explain that a little bit?
Well, I probably should know, but it was just so complicated and so complex why she would think that polio was not possible. So it was always a challenge to continue to inform her, particularly when China in the Western Pacific had embarked on the strategies, and they clearly, like Brazil, demonstrated that in a large, challenging country, you can do this. There were under-the-table debates about OPV versus IPV. In fact, before embarking on India, my first trip to India actually was with Cyril de Quadros to attend a WHO UNICEF meeting in Delhi. So it was for a couple of days. I remember it was at the French hotel down on Jampath, down near Connaught Circle. It was a beautiful hotel, and this large international meeting that debated the pros and cons of both vaccines. And India was using OPV vaccine, and they were being pressured to switch to IPV. And Dr. Soki, who immunization came under her, received Dr. de Quadros in her office, and I remember going there and having this discussion with her. She bought into OPV as the mechanism in poverty in particular to flood the community with the vaccine. It had the herd immunity. She knew the routes of transmission, and it made sense to her despite the pressure. It was cheaper. India at that time had this extensive network. They sampled some percentage of all the vaccine they distributed throughout the country, took samples from points of service, and did potency testing on the vaccine, which was a way, an indirect measurement of the effectiveness of the cold chain in maintaining potency. Now, it wasn't clear what they did with that huge amount of data. I remember being asked all the time, forget in the moment who, but different experts from CDC or elsewhere, what are they doing with all that data, John? Can you find? And Dr. Soki always claimed that when I'd asked the question very diplomatically, how do you manage this data? What are you doing with it? Yeah, so this is our way of ensuring that a potent vaccine is being administered at a huge cost. So that was going on. So I don't really quite understand. I think she was also concerned about the differential diagnosis of acute flaccid paralysis. I think that's why she tasked us very early in the game with developing the field guide so that she could better understand the science that was available at the time. And so she was quite interested. She was fascinating in that she did want to learn as much as possible. And fascinated by the fact that Jamaica, I think it was, may have been in the 70s, had an outbreak of enterovirus, 68 or 71, one of the enteroviruses that also causes outbreaks. And that differential diagnosis, she was very sharp. Can we handle that? Can we really develop the specificity required to be sure that this was polio? And I think she had her doubts there. So it wasn't her source of anxiety and lack of optimism, I think, centered on the vaccination strategy as well as the ability with the India infrastructure at the time to detect accurately the pools of transmission. So as that's happening in 1994, Surat, I think it was in August, but it was in 94. Surat is a poor city, I believe in Gujarat, that was noted to have a cluster of deaths. And those deaths were quite concerning and made the newspaper. Then someone observed that there was a rat die-off. In the same community, they saw an unusually high number of dead rodents in the streets. So someone else put two and two together and thought, this is the plague, which to this day we don't know if it was the plague. It could have been hantavirus. It could have been a number of other agents. But it basically, as we discussed previously, highlighted the fact that the capacity just wasn't there to identify in this particular emergency that cost the nation millions, if not billions of dollars in tourist revenues because of this scare. It went global. Indira Gandhi Airport in Delhi was shut down. Different embassies sent their staff at home. And I'll never forget going around with Dr. Harshvardhan on the 2nd of October, Mahatma Gandhi's birthday. Everybody was wearing masks. All the vaccinators were wearing masks. A lot of the community was wearing masks, and because of this Surat scare. There was now that talking about courage, he was pushed to postpone the campaign. He was, the pressure must have been enormous, not to do this in the nation's capital. There's this potential of spread. We're not sure what's going on. He decided, no, I must do it, and we're going to do it. So with that backdrop, for him to go forward, that was incredible. That was just amazing. So I have an enormous amount of respect for Dr. Harshvardhan. He's now the Minister of Technology in India. So from state level to the minister of this huge ministry and tool that supports growth, technological growth in India.
So the lesson from 1994 in Surat is that India needs surveillance.
Correct.
Infrastructure. Okay.
Yeah. It needed surveillance big time. As I recall, I once asked John Rohde, who was the UNICEF representative, how many schools of public health are in this country? And I think his response, there are only 2 or 3, and he knew them, of a country of 1 billion people. Now that situation has changed. There are several now, probably still insufficient number to keep up with the demand of human resources to be in place at the right time, the right place, and be trained and empowered with the necessary tools. So if you're thinking, 2 schools of public health, I believe one was in Calcutta, but largely a public health service that was operated by clinicians that did not have, again, the visual Kaushik's office reporting system. There was the National Center of Infectious Disease, of National Center, I think that's what NCID stands for. I always remember NCID, but that was their equivalent to CDC. It was a beautiful campus. It was where the smallpox team was housed during those years. Beautiful buildings, these old, beautiful architecture, and that was where the polio lab was. And I'd go out there to see how the work was going, but it was far from what was necessary. So there was this opportunity. And we used it to its full advantage. At the time, there were a number of partners in India. It was an interesting setup. The British would have certain states, like West Bengal, for example. The Danes would have another state. And depending on the donor, I think the Danes were interested in Tamil Nadu. I may be wrong, but you get this picture where the nation was divided and linked to certain donors. So it made the situation fragmented. If you're coming in trying to develop consensus, develop this vision and strategy where everybody's working together, everybody's reading from the same page to get to the target, it was challenging even amongst the donor partners. But there's always a silver lining. And so despite this tragedy and the loss of resources, revenue as a result of the Surat situation, the Danes, who were always one of those partners, like many of the Nordic countries, interested in strengthening capacity of health systems, they were not interested in disease-specific programs. At least that was my take on it. And so we were challenged to present the program as an opportunity to strengthen health system. And it actually wasn't a challenge. It was like falling off a log, because I'd been through Polio. And I saw firsthand how that helped. And I went to the Taylor Commission meetings where Carl Taylor chaired this commission, and Felicity Cutts and Julio Frank and these other huge global leaders participated in an evaluation that took over a year in Latin America to answer the question, what was immunization, EPI, and polio eradication, what was the impact on health systems strengthening? So I'd been through that. So to develop the argument was not, I guess challenge wouldn't, I wanted to be able to provide that and share that experience. So the Danes then, a fellow by the name of Bjarne Jensen, was the equivalent of the director of health in the embassy, the attaché for health, Bjarne Jensen. And Bjarne was a charming guy, friendly, all business, that, John, this is not an area we want to work in. I'm sorry. So when Surat happened, and I'm going around, I'm making the rounds because it was important. I always learn from Cyril, you don't just visit JICA once. You go there 5, 6, 7 times you present the different message. You present the same message, but in different ways. It's just you have to be determined, I guess, is the word, or persistent. Persistent is a better word, because it's not just a one-off communication. So follow up, and that was what we did with Bjarni. And oftentimes I would take Kaushik with me, and we'd have a coffee. We'd show him what was being done and what needed to be done. Well, it's when Surat happened, the conversation changed. The conversation, that silver lining opened his eyes, because he saw this opportunity to strengthen systems in India through surveillance, with the entry point being polio eradication. If polio cannot do it, then I better advise my government to think differently. Perhaps what we're doing is we'll keep on that track. Let's avoid immunization, polio eradication, because India can't do it. And when you meet these partners, they're all accountable to their legislation back home. So there's a risk analysis. They want to know in great detail, what are the risks of failure? Well, first of all, they want to know, what does success look like? What are the risks of failure? And how do I sell what you're telling me to my own government, and then over time report back on their investment? So the monitoring and evaluation component is also very detailed. They had what we put together. I'm sort of jumping ahead, but he basically bought into it, and that led to, in 1996, I believe. Yes, it was 96, because the first India NID was December 95 and January 1996. And that was the one that targeted less than 3-year-olds because of the supply issue. 2 months later, after the second round, we'd been through the Surat experience. We had identified this huge risk to the nation's capacity to respond. In a meeting of interested partners in March in New Delhi, it was probably the first regional interagency coordinating committee. The equivalent in PAHO was chaired by Dr. Bill Fahey to mobilize resources for polio eradication. Dr. D.A. Henderson chaired the technical advisory group, and Dr. Fahey chaired the interagency coordinating group. So this equivalent in Delhi provided an opportunity in one room to present the strategies, the progress, the needs, the resources, and the gaps to those resources. And then I remember going around the room, and when it got to Danita, we're having these conversations leading up to this meeting. They made the announcement. We have nothing finalized, but we're very interested in funding polio surveillance. And to say that in front of everybody, AID, JICA, World Bank, all these key players in the region, wow, what's going on here? So that then led to finalization of the agreement. There was a lot of last-minute hiccups because WHO had an overhead, what are they called? It's like the overhead costs of running a project that pays the light bills, those sort of things, computers, mailing, and that overhead cost for managing a program in most cases is like 13%, which studies show is still far below what is necessary to run a program. So many things, costs are cut, particularly salaries and things like that, in order to meet. Well, Danita was absolutely firm that we're not going to pay anything above 6%. So I'll never forget that. It's like we have it, but yet we don't. This is a huge deal breaker. And we were, eventually the director, Dr. Rafi, decided to give an exemption and allow the lower percentage. But every time I walked into administration after that, you could tell, oh, there he goes. he's cut, basically shut the door on the opportunity to keep our office, our building functional and stuff. But they finally agreed to that, and then resources started flowing, and then we were able to have the training of the first 59 surveillance officers. So that would have been, I believe, in 1997, when funds were starting to come in. The training we elected to have at a Muslim college. We felt that perhaps strategically that would help us in the future cross that gap in collaboration and coordination. It's a beautiful campus in Delhi, and it was just a 2-week intense training, long hours, but it developed this camaraderie that was amazing years going forward. It was amazing to see, to this day, when you run into an SMO from the first team, they're very proud, yes, I'm an old timer, and they actually have a little, I think they have a little club that they communicate. But it's a badge, almost like a badge of courage. I was in the first group, and it was, we were supported at that time. Dr. Haladi had come to India. I'd been able to create posts for WHO polio medical officer in the 5 priority countries: India, Bangladesh, Nepal, Myanmar, and Indonesia. And so having a CDC-trained epidemiologist like myself, who had been through PAHO, bringing in a broader-based team in order to get the job done was absolutely essential. I remember Dr. Haladi being there. We also had support experts. One name who comes to mind that was incredible was Dr. Anna Maria and now Restrepo from PAHO days. Who, when you look at her attention to detail and her ability to work in the field was incredible. So to have her with that experience and talking at tea break and being able to convey her experience and then translate it in the case investigation forms and those kinds of details was amazing. What we did, I think, that helped us use the data to manage. So not necessarily use the data to, of course, you use the data to know where the disease is occurring and directing your strategies and where you need to make your site visits, but also use the data for program performance. So there are indicators in surveillance. If a reporting site is not reporting or late or consistently late in reporting, the data is of not high quality. Just based on those 2 things, you're making a site visit in the next 2 days to go find what's going on here. You don't come in with that attitude. You come in, to empower that person, but you're pointing out, this has to be done because if it's not, we won't know if you have virus. You may have virus and you're not going to be picking it up because of these poor quality performance indicators. So I think that was additional value added that she brought to that original team. And Kaushik Banerjee was there. Kaushik, he was this figurehead who everybody looked up to. So he, in sort of creating the atmosphere of teamwork, collegiality, spirit of corps, Kaushik was in the right place at the right time.
I wanted to ask you, just made a note, you mentioned the attitude that you use in approaching someone to empower them rather than critique their work.
Yes.
Could you describe that a little more, how you do that?
Yeah, that's a good question. I I can share an experience in Malawi after arriving there, and in the first few days, you learn that there are only two sets of instruments to do a cesarean section. So if you have more than two women in labor who need a cesarean section, that's a challenge. And we learned to get over that challenge by basically rinsing the instruments, pouring alcohol on them, and then lighting it on fire. And as you're doing one Caesar, that's cooling off so that you could do another Caesar. So in that sort of environment, in a hospital that had no running water, no electricity, I'll never forget standing, observing. In those first couple of weeks that we landed, and my wife, who was a nurse, were observing those that have taken care of neonates. There's what's called a butterfly intravenous needle. It's butterfly because it has these two plastic arms on the side of the needle that you can squeeze, and it allows you better control in getting into that teeny weeny little vein of a neonate. And usually it's one of the scalp veins. You put a rubber band around the scalp to have it expand, and then you have a fighting chance of getting that in. But it's designed so that you can get that needle in. And then once you get it in, you pray that you can tape it down without it sliding out, and then you can hook it up to the IV for the antibiotics that this baby needs because the baby's in sepsis or has meningitis or has some other problem. Well, so with that backdrop, we're standing there, and there may be two or three, just two of those in the hospital. We hope to get someone from London visits. I've sent a message, bring a box of butterfly needles, or the last time we went into Lilongwe, we were able to scrounge up a couple, that kind of thing. So there are only a couple, and I'll never forget, she opens it up, she takes the needle out, and she scrapes it on the counter. So this is a sterile needle. She scrapes it on the counter and then begins to put the IV into the vein. And we both just... Now, I think I was in such shock that it was fortunate because I didn't jump out. So that I always use that in my mind. How do you engage? Because you can't just come in, what my dad used to always say, a right hook. You have to come in and be positive, but then know and strategize when you're going to give that message that in other circumstances might be offensive, might offend that person, and how to use it in a way that it now gives them an opportunity to do a better job, and they realize, oh wow, I've learned something. Yes, I can do a better job. And so if we had come in and said, this is absolutely wrong, it's no longer sterile, we would have lost any opportunity to work over the next 2 years there, because she would have spread the word that here's another arrogant outsider gringo telling us Malawians how to do things. So gradually over time you train them on sterile technique. You begin hospital ground rounds. They've never been exposed to continuing medical education, so you empower them. Same with the site visit. So when you go to and you see a problem, perhaps not as severe as this problem, it's dealing with public health data management and follow-up with using the data and evidence, you empower them. Well, why did you choose this site to visit yesterday when we know these two sites over here are having... So getting to that point where you can talk and candidly, it takes a little time, building trust, leading in. So that's my style. And it seemed to work for me. People in leadership positions have different styles. If you compare the leadership style of Cyril de Quadros or D.A. Henderson or Bill Fahey, They all have different ways of approaching the same thing. And interestingly, they all got things done.
But how do you build trust? That's because I'm thinking about the soft skills, and teaching stories about these kinds of soft skills.
Yeah. So I teach a global vaccinology course that, from the idea on bench science to the downstream, when the needle pricks the skin, and the time period from the thought to discovery to vaccination, maybe 15 years, if not more in some cases. And all along the way, we teach components of that. It's over 10 weeks. And there are two themes that I try to run through it, and it's leadership and coming back to the polio case study. So if, for example, in week 3, we're talking about vaccine immunology, what are the important components of the science of immunology that helps with vaccine development? What do you as students need to understand at some level? We give examples of the challenges of HIV, or you name the antigen. And at the end, I come back to the polio case study. Well, this is how polio was handled, and it's a 15-minute sort of wrap-up. So all along the line, they get exposed to certain elements of the polio story, and then with that, the leadership. So I was able to interview, I had tape from interviews that I conducted with Cyril de Quadros when I was deputy director of PAHO, with D.A. Henderson there asking questions, so I can use those resources. But what I'm struck by in preparing this class, I'm sorry I'm taking so long, but is there's a book by, I'll think of John Maxwell. It's a little sort of airport self-help, one of those books, the carousel in the little bookstore where you buy your gum and what you in the magazine you're going to read on the plane. And it's one of the best books on leadership that I've ever purchased. And you can read it on a plane flight because it's a little, and at the end, he uses this phrase, learn, earn, return. 3 words. Learn, earn, return. So you, as a student, learn, but never forget the fact that you are a student for the rest of your life. Then you earn respect. Your question, how do you get that respect and trust? And then throughout your life, you return by mentoring. You take every it's your duty to mentor the next generation. You are blessed, you are fortunate to be put in these situations, to have this, be a part of something bigger than yourself, say. But the part about trust is, that I think is key, that I see in every very effective leader, is that you never ask anybody to do anything that you yourself would not do. And you show that over and over. You don't just show it once, day to day. You show that. And you demonstrate that this is something, I'm there with you. I will stay up all night with you, or I will do this with you. But, if I'm calling from Delhi and they know that, and you say, okay, I want this report tomorrow, they'll do backflips. Because they know you would, if they asked you, you would do the same. So there's this sense of, that's the spirit of core. You talk to people that had worked with D.A. Henderson, for example, Cyril, of course. But if you talk to them during their smallpox, what happened during their smallpox, there's a certain cadre you constantly come across that say that he would have done anything for us. And once that person admits that, then they're in it. They are totally committed. So, amazing.
Thank you.
Yeah.
Next turning point. Let's see. So we were talking about surveillance. Was the National Polio Surveillance Project called the National Polio Surveillance Unit prior to becoming the project? Was there a progression there?
I don't recall. I don't know. What I do remember, when funds from Danita became available, the first office was in Nurmambawan. And that was It was a battle. I didn't want the office to be out of Nurwan Bawan. Nurwan Bawan was where the leadership was. That was where, if you were having a problem and you needed political commitment to support the worker bees, you could walk down the hall. And so I felt very strongly about that. And there was some reticence, but finally they created space. Whoever's making that decision is getting it from all different angles with similar questions. Sir, madam, we need space. Can you give us more office? We've got 3 people in this space. We've got 5. So it's crowded. But so finally, whoever made the decision gave us this office. And so you take Kaushik's office and maybe multiply it by 3. And that was the first office space. So it was very crowded. We were able to get 4 or 5 computers in there. And I think at that time is when Dr. Halati came to India.
Was Julie Jenks also?
Julie was also there. I'm not sure when she arrived, but she worked very effectively with Dr. Halati as sort of his right arm and operationalizing things, managing budgets and so on. So she came. I'm not sure if she was there in that office, but here's what happened. You can only, someone defined humor as pain plus time. Well, this is kind of, so the new equipment, new furniture comes on a Friday. I think Thursday, Friday, it's beautiful. This is wonderful. And someone leaves the window open that night. So having been in Nurwan Bawan over many, many weekends, the monkeys come in down the streets, these beautiful streets with these huge trees. There are a number of monkey colonies. And they take over the ministry. And so many a time, Kaushik always says, "Don't look him in the eye, don't look him in the eye," as we go up these windy stairs to his office. And around the corner, there'll be this, male, so you kind of go by them like this. And the other thing I remember is that the stool stood up like little rockets. So you'd look down these long, wide corridors, and you'd see these, leading the way, these stools. They were monkey stools, excrement. So, and then they'd clean it up first thing Monday morning before the rush came in, so that everything was swept out and mopped up. But with that background, so the window was left open, and Monday, well, the monkeys had a party in there. The monkeys, there were papers strewn about. I seem to remember that as if one of the, it might have been a printer or something, was almost like as if it had been thrown across the room. They peed everywhere. There was extra. So much of that equipment was damaged and lost, to Bjarne Jensen's chagrin when he found out this. So this is how our money went. And, anyway, so that happened, and it sort of led to a decision to push polio out of the ministry. It wasn't going to survive in that office space, number one. It was just too small. But eventually there was a soccer stadium or a cricket stadium in Delhi, and under the bleachers they had constructed these offices. So it went to one of those places. What I tried to avoid in those early days was this fragmentation, and so distance contributes to fragmentation, and so we made every effort. I think Gary and Julie and others on the team, Kaushik, made every effort to keep Dr. Sobhan Sakar informed, to not make that distance a barrier. Because it's all about collaboration, keeping the government engaged, and you're doing this work for the government, and that the government take credit, and that you're working in that way. So that's how started. So the terms, I don't know if it was called a unit or a project, but to this, it was for many years called the National Polio Surveillance Project after the proposal that we submitted to Bjarne Jensen and Danita.
I tried to do a little bit of learning about surveillance systems and setting them up and evaluating them. And I read that you have to balance different characteristics depending on the disease. So I was wondering if you could talk about the surveillance system that was set up for polio in India and what was important.
Yeah, great question. So the system replicated the PAHO model, whereby there's the 4 pillars of the polio eradication strategies. You have strategies that do everything to reduce the number of susceptible children to infection, to reduce that pool as rapidly as possible using oral polio vaccine. There's that component. We'll come back to that component. The second is having a surveillance infrastructure in place that provides the sensitivity, captures all the reservoirs of transmission, and the specificity that this is not enterovirus 71. This is wild polio virus type 1 or type 3. So that, in a nutshell, is the approach. Now, on the vaccination side of things, there are 3 strategies. I benefited from my experience in PAHO, recognizing that the importance of essential immunization, what people call the Expanded Program on Immunization, EPI, that was fundamental to the 4 pillars. On top of that, when you achieve good coverage, you always strive for the best. On top of that, you need these campaigns that very quickly reduce the pool of susceptibles, displace the wild virus in the community with the vaccine virus that allows actually for secondary transmission. If you vaccinate one child and another child who has not been vaccinated gets exposed, they'll get vaccinated with that vaccine virus. And that's a side benefit. And so that contributes to what we now call community immunity. Those that didn't receive the vaccine benefit from this indirect vaccination, plus the community immunity effect that even if you're susceptible, you're surrounded by this wall of protection of other children, and which then leads to interrupting transmission because the virus is smart. It can't find a susceptible child, and it can't survive. It needs a body to survive. That's the nature of viruses in general. They need human cells in the case of human viral pathogens. So that's an important strategy, and that would be what we call the National Immunization Days. One day every year, followed in 4 to 6 weeks, say, by a second round, another day. So they were consisting of 2 rounds of the oral polio vaccine, targeting all children less than 5. Then the third vaccination strategy, which in Latin America we used in those last remaining reservoirs of transmission, you've knocked transmission down into local areas. Then you could go in with a house-to-house mopping up strategy. So, and then the surveillance components, as I referred to, having the elements that would lead to high sensitivity, so a syndromic reporting system. That syndrome is the acute flaccid paralysis with many causes, but you're capturing all the polio through that mechanism. So you may have Guillain-Barré syndrome, you may have Coxsackie or other enteroviruses, transverse myelitis, a whole laundry list on your differential diagnosis. And in there, you'll be pulling in the polio cases. But to be sure that that paralysis is caused by polio, you need the specificity, the laboratory backup. So you collect specimens, stool specimens from the child, get the laboratory to examine them, test them. If it's polio, they will isolate the virus and characterize it as to, is this type 1 from Pakistan or type 1 from China? So with that degree of specificity, it gives you amazing information and allows you to track the progress of the program and when you've crossed the finish line. Allows you to say confidently that you've stopped transmission. So the model was developed in PAHO, largely through the genius of Cyril de Quadros, and I brought that experience. People always question on the vaccine side, can't do an NID in India. We talked about that. Using the data, showing the Brazil graph, sharing experience of other countries like China that were successful. And then when Bangladesh took off, that a flurry of activity, commitment. Well, you can't do it. Oh, yeah, we can. Okay. Then, routine immunization is hard. It's hard to reach every child, and I don't know if we can succeed on that. So what we did, I think it was in 1995. You think of India, Bihar, Uttar Pradesh. Uttar Pradesh, if we were to call it a country, is the 6th most populated country in the world. Number 6. If we call Bihar a country, it's number 9. So this is mind-boggling. So you have to decentralize. You have to decentralize. And what we did was take the ICC idea, model, the Interagency Coordinating Committee at the national level, decentralize them to the state level. And at the state, it was beautiful because UNICEF had its tentacles down into the communities. They had a number of states where they actually had a state-level office. It wasn't like WHO, where you only have the WHO office in Nirman Bhawan, New Delhi. You had your partner who had this network that was huge and an opportunity to help with the strategies. So the UNICEF offices in Lucknow for UP, Uttar Pradesh, and Patna, the capital of Bihar, were both behind the strategies. The directors of those offices were very convinced that we could do it, despite at times whatever messages were coming from the Delhi UNICEF office. John Rody, who I got to know early on in the game, was someone who had been there some 14, 15 years. The Indians highly respected him. I knew that it would be important that I convince him and and engage him as a very valuable equal partner. And he held a regional meeting. UNICEF has a different sort of structure. They have a South Asia office that's in Nepal, but he brought in all the country directors and allowed me to give the case, to make the pitch. And they decided we have to do it. And so that helped. John, though, left and others came in as his successors. But at the state level, you had these highly committed people, one of whom I remember every time we went to Lucknow, I thoroughly enjoyed going to a park with him. There's a form of yoga that you start your day at sunup laughing. And it's sort of a men's club. They were all men, they were all men, but they would congregate there in this little park, and someone would start laughing, and then somebody else would start laughing. And it would be impossible for you not to start just this belly laughing. And this rush of endorphins to start the day was wonderful. So I always like going to Lucknow to visit. I can't remember his name, but he was a gentleman, a very charming man. He got behind it, and then the fellow in Bihar got behind it. So in Bihar, we created the ICC, and we named it Bima. And in Hindi, that means insurance, Bima. So the message is you insure your child with routine immunization. with the EPI antigens. It's not just for polio eradication. We're promoting the essential immunization program as one of the 4 pillars. We will use polio to benefit that, and vice versa. They got it, they were doing it. Same in Lucknow. It was called UPALA, which had an equivalent meeting. I can't remember exactly now, but it had that same message, positive message. You know, in PAHO during Vaccination Week in the Americas, we used a motto of vaccination is an act of love. You know, you're loving your child when you vaccinate them. So that was our model for Vaccination Week in the Americas. And similarly, these committees got branded with these nice labels that promoted and strengthened a mission where everybody's reading from the same page. What I remember in Bihar in particular, there was a milk distributor that, if people use the Coca-Cola analogy, you're in Africa, you're in this jungle, and there's a bottle of Coke, and it's cold. How did it ever get there? Why can't we use that for polio eradication, the cold chain, and so on? So you hear that a lot. Well, in Bihar, there's this milk distributor. In India, everybody has their curds, their yogurt, and their milk. And it got to every village. So we got them to be regular participants in the meeting, recognizing that they would impact the cold chain. There was a women's group that was, you know, I'm speculating, but it's probably not far off. Probably one of the largest women's groups in the world, empowering women of poverty. They came. World Vision and others, that these partners that you wouldn't necessarily run into in the Delhi meeting. This decentralization pulled in a different cadre of civil society, leading pediatricians and so on, with this mindset, we're going to improve essential immunization program. And that started, I believe, in 95, 96, but later was discontinued, unfortunately. So the UNICEF leadership, I wouldn't say use the word paranoid, but there was a bad experience with the universal immunization program in the 80s. The countries around the world, under the leadership of Jim Grant at the time of UNICEF, with some WHO collaborating leaders, promoted this idea that all countries would achieve 80% national coverage by the year 1990. We knew that in the Americas, I saw it firsthand because I started at PAHO in 1989, that a country like Peru, for example, had administrative data, and then in a community, a localized community, they did a survey, got a higher coverage, then they averaged their national administrative data point with that finding from the study of this locality to come up with a number that was above 80%.
So that's inflated.
We had to explain, no. This is not high. So countries were driven to achieve the target. They started realizing that funding streams might be related to this. There were negative consequences of what was an admirable effort led by Jim Grant, who was an incredible leader. And so I think there was this, are we going to repeat this? And the government has to take ownership. And that's what was happening. That was not realized, that this was being owned. Those meetings of BIMA and UPALA were chaired by the Secretary of Health and Family Welfare at the state level. So it was owned by them.
Not UNICEF and not WHO.
No, but we used their offices, we used their networks, and it was, we had a secretariat to support the leadership by writing the note for the record, following progress, preparing for each meeting, making sure that as many partners using this, UNICEF had this extensive reach. So I guess it's unfortunate because the necessary support for the essential immunization program was not sustained. And then India, as a result, had to rely on campaigns. And so getting back to your question, what was, the strategies, perhaps were they accepted and would they work? If I understood you correctly, yes, but mistakes were made. I could cite the mopping up in Orissa, probably one of the better ministers of health I've ever, well, Dr. Harshvardhan rates up there, but the minister, she was an amazing leader who wanted to see polio eradicated in her state. And there was a cluster, if you followed the epidemiology, looked at the SMOT maps over time, they were becoming more local. The experience in the Americas when we did mop-ups, we were targeting communities that may have had 9 cases, 9 wild virus, 8 wild virus cases, as in the case of Colombia in 1991, or Peru, 1 case, or Central America, the Pan American Highway going down Central America, 3 cases. And we target the coast of Colombia, we targeted 1 million children to be vaccinated. Peru had a large number of children with these small numbers of cases. So with Orissa, it was a different situation where you had that would be contiguous districts, so a little wider, perhaps geographical area, but with much more intense transmission due to a number of factors: population density, sanitation, water, so on. She wanted to do this mopping up. Let's go in, clean it up, get the job done, and write this one off our list. And she led a beautiful program and I said, Madam, maybe we should wait, knock down the transition a little bit more. But she was dead set to get it done, and she did it. So I would use that as a message. Orissa is one of the 8 poorest states of northern India. I've talked about Bihar and Uttar Pradesh. Well, there are 6 others: West Bengal, Rajasthan, Maharashtra, Orissa. And they present enormous challenges. And so for her to be able to do that was really a benchmark, that mopping up strategy works in India. So that another PAHO strategy coming to be used in India, and with clear data showing the vaccine works. You have good micro-planning, you have good leadership, this best, amazing person in charge, and you're empowering your teams, you're not missing children. It gets the job done. And so that was something, and when I teach this class now and we talk about the pros and cons of each vaccine and what is it that requires success, I always cite her.
Can we take 5? Thank you. So we're back from bathroom break. So I was interested in hearing from you about the surveillance system and what polio virus, wild polio virus, what was necessary for surveying wild polio virus, and how you set that system up.
Yeah. So an assumption, and fortunately the assumption is proved correct. When a family has a child that develops acute paralysis, they're highly likely to go to a health center. They, in most cases, again, highly likely to go to a traditional health center as opposed to a non-traditional, perhaps, that's not linked to the surveillance network. But that fact allows you to think about reporting sites and establishing a network of reporting sites that will capture all cases. So you start thinking through what are the characteristics of a reporting site, and how you then strategize the inclusion of those sites that meet those characteristics. That in mind, you want a reporting site that serves a community that parents typically go to with this kind of an emergency, that staff, even those that are challenged with lack of resources at the beginning, your target is to strengthen their capacity. So it goes beyond polio in that sense, to provide better services and respond to situations. So establishing the network. I always say the most important thing in surveillance, public health in general, really, it's about people. So that's the beauty of creating this program that's grounded in people, that's people-based, the surveillance medical officer. I learned in Malawi, in the district medical hospital, when you start teaching, it's like pouring water on a flower. People blossom. They want more. They know that knowledge gives them the opportunity to do great things, or to feel better about their job, to keep engaged. So that needs to be built in. So you create a network of human resources that are going to support and empower these reporting units. The SMOs need training. Fortunately, there are documents, field guides, scientific literature, information, evidence that you can use to craft your training program. Always linked to leadership, management. You can have good managers. You're my boss. You're checking my time clock. Okay, I'll fill these requirements that you have as my boss. As opposed, you're my leader. You do all those things, but you have a vision. I have a sense that you're taking me somewhere, and you're strategizing. So those were things we tried to empower. Get back to this term I use frequently, esprit de corps of the SMOs. So what you're ultimately striving for is achieving the target, but doing so with technical and operational excellence. So the norms and standards that you use to train people, that you use as case reporting forms that collects the data, you're entering the child's address, the other identifying information, birth date, family, address, that kind of thing. You assign an identification number that protects the child's identity, but links and serves as the guiding stamp of that child's information through the data system that the lab, once it gets the specimen, can report back to and be a key link, this case identification number. So using the norms and standards of what are the best practices, but the science, the current sciences, as things need to be modified, revised, improved. The operational excellence being addressed through the management skills and leadership skills you give folks. But it's almost, not to oversimplify, but when you take somebody who's committed, wants to learn, and you empower them with a car, a cell phone, and a computer, it's amazing what they can do. It's just incredible. Office, eventually, some support staff, and that network that started as 59 then gets tripled, if not quadrupled, throughout the country, because we realize that actually every district, and I forget how many districts are in India, It's a huge number. Really, every district needs a medical officer to help manage this program, ensuring that they get across the finish line with good data production and good data evidence to demonstrate that. So in those early stages, you can set up a system that allows you to track performance. I think I said earlier how if you're following that reporting site and performance indicators on that reporting site, timeliness, completeness of data, it's not a silent area in your system, then you can use that data to target supervision and support. Much of this, 80% of it, is about management. Public health practice involves management. And so those officers are trained to know how to identify, target, and follow up areas that need their support. They're trained to create a space of interaction, that they're not just coming in and hammering on somebody, that they're supervising them skillfully. So they're provided that. The network starts initially sort of at a Delhi-based level, and then later over time it gets decentralized. So today as we speak, there's an amazing office in Lucknow, same in Patna. There are other what are called regional offices that has decentralized the leadership, management, and appropriation of finances that requires the work to get done. So getting back to your question, it's operationalizing things in the beginning that's going to leave a long-lasting impact on how it's managed in the future, that creates spirit of core, uses the best science and evidence available to establish a surveillance system that's going to capture just about every wild poliovirus. Now, because there's silent transmission, it's a very challenging disease. So you really rely on that polio lab network, the quality of that network. And that has to be linked with the surveillance medical officer. The epidemiology and the virology needs to be linked and conjoined at the hip. If you don't have that, then things start to malfunction. And fortunately, India had a very strong, it built up. It took time, but it built up into a very powerful, strong network. And there were great virologists like Dr. Deshpande in Mumbai. Amazing. I hope he's still alive. He was an amazing virologist, amazing leader. And we were able to bring in the CDC team, Dr. Olin Q and Dr. Mark Palanch. They made regular visits to the country and all the workshops we had, all the training and all the visits. And they provided samples for quality assurance testing and all the work that goes into that. The sheer volume of these AFP cases and ensuring that the capacity grew to meet the demand was absolutely enormous. We had to create new laboratories almost out of nothing. I remember the Calcutta experience. There was a School of Public Health, that one I mentioned in India, had a lab, and we had choices. Should we start it there or in another medical school? I don't recall all the details, but we had to sort through the likelihood of who was going to perform better and be committed and sustain the efforts. And I think we made the right decision. And so as a consequence, that lab started from a much lower capacity level than, say, Dr. Deshpande's, Jagdish was his first name, Jagdish Deshpande, a true gentleman. The Bombay lab was already doing state-of-the-art research, globally recognized. So it was a no-brainer to make his lab the regional lab, designated as the regional lab in India. And we brought in, to manage this network, as I had done in PAHO, we brought in great expertise. There was a Sri Lankan virologist, I'll remember her name, but a dear, dear person, who coordinated and ensured that there was this, that the two were linked, the epidemiology side and the laboratory side. So getting back to the differential diagnosis, the laboratory becomes absolutely critical in a polio eradication program. It's very different from smallpox, very different from measles. Measles, if you see a child, measles presents with rash and fever virtually 99% of the time. There's no ifs, ands, and buts. The differential diagnosis is there, but it's a presentation, a clinical presentation you can count on. Rash and fever, no silent transmission. And so that's the major difference, and to a large extent explains why you need this support. And with that support, we were able to document the last wild poliovirus type 2 isolated was 1999. We didn't know it at the time, but it was. And it was in this village in Meerut. And I remember on my birthday, March 14, 1999, going to visit that house with Kaushik Banerjee and seeing the living conditions, almost like an open barn, ramshackle, three-sided dwelling with an open face to the goats and the chickens and the mud in front with the children playing. And that was a petri dish for polio virus transmission. So a likely an event to happen there, with a child being paralyzed with the last case on the planet. So that was for us, that to learn later, that was it was nice.
Have you spoken with Kaushik about that? Have you reminisced about that at all?
Yes, Kaushik and I was texting him as of yesterday, because he's engaged. He works for WHO Geneva now. He has a wife who's also an epidemiologist. I don't know who she's working for, but they live in Geneva, has 2 children, a son that went to Purdue, I think, School of Engineering, and I forget what his daughter's doing, but a great family, and he has a great sense of humor. And my humor is at the 8th grade level. I'll laugh at most at anything, and he, unfortunately, I always told my mom, I think that's why I love you so much, Mom. You laugh at my jokes. And so it's kind of like, she had a belly laugh. Anyway, Kaushik always, you have to have humor in these difficult situations. That's what keeps you going in a way. So yeah, Kaushik and I, we see each other. The world of immunization is a small world. You run into friends and colleagues all the time. It's an amazing benefit. And my personality is such that I like to go. I'm an introvert. I like to go recharge by going to my room and thinking about processing. My wife, who is an extrovert, gets recharged by going out after dinner or after a day's work. But Kaushik always understood that, and we had a very nice collaboration and friendship.
Do you remember his response to seeing that, what turned out to be the last case of type 2?
I think we were making routine visits, and it's interesting. I tell this story because there's an effect. When you live in India, the first year is tough. You have to adjust to the huge temperature variations. The heat of the summer is almost overwhelming. 118 degrees. Imagine that. Walking outside, it takes your breath away. And it's very, and then the pollution, the inversion in the winter is very toxic. But despite that, it grows on you, particularly when you get out of the urban environment and you go to the field, you go to the south, you go to other places, you go to places like Bihar, and the whole Ganges River Valley is beautiful. That's why I like going to Bangladesh so much. The rice fields, the sunups, the sundowns are absolutely pristine. But you see things, I'll never forget, I had a British medical student staying with us, and we were driving, it must have been Lucknow, it seems to have that kind of image, and there was a cow, you see cows everywhere. They stop traffic, but there was a cow that was dead on the road, and there was a pack of dogs that were pulling at the intestines, and at maybe 10 yards, the dogs were, you know how they're pulling and pulling. We would drive by, and I kind of look, and I'll never forget, she started hyperventilating. She was very shocked to see this. Nobody else in the car was reacting. So we'd been there long enough that we're kind of numb. And I thought, I always remind myself of that experience afterwards, because it kind of sensitizes you to be aware of others in that kind of setting and how they might react. And she was visibly upset. And anyway, so I cite that because in seeing this poverty, yeah, this is where polio is, and you kind of like move on. You got what do we have to do by the end of the day? Where are we staying that night? That kind of thing.
Let's work. Could you tell me the story of the 59 surveillance medical officers, SMOs? And you've already talked about the training a bit, but are there stories that you could share, memories that give us a little insight into what that group was like? What their experience was like?
Yeah, there was one fellow, I'll never forget the first time I met him. He came up during the training, and he introduced himself as Dr. Prakash Singh. And little did I know it at the time, he would eventually become the regional medical officer for Uttar Pradesh. Remember, Uttar Pradesh being the 6th most populated country in the world. And he led the charge in Uttar Pradesh eventually. Well, at that time, I say this because it's kind of, there are these interactions that you don't expect, kind of like, and that then you kind of struggle to regain your composure in a way, or it wasn't that severe, but I remember he came up to me, he says, I think he was from Gujarat, and that he was a sex therapist. So, kind of like, trying to hold the urge to giggle, or, you're what? So we had that exchange. He became a very good SMO, and I'd ask him, well, what got you interested in this? And he says, well, I was in the Air Force, and I like having structure and this and that. And so you meet these personalities with different experiences. An example I just cited. But across the board, they were just highly dedicated. They were there, they wanted to be there. And then, so I left India in 2000. I left, we had the lowest number of cases ever reported, 264. Transmission had been isolated to the 2 states, UP and Bihar. And when you think regionally, Bangladesh, Nepal, Myanmar, Indonesia had stopped transmission. So I left under circumstances I didn't want to leave. I wanted to see it to the end, but for health reasons, had to leave. I was told I had to leave. Because the year before, in 1999, I'd had a cardiac event. It wasn't a myocardial infarction, luckily. There was no muscle damage, but I had a blockage of my right coronary artery. So I was medically evacuated. I came back and tried to stay on the, stay in the game on the playing field. But after a year, it became, it's just a lot of stress. And my care providers and my family said it's time is, so we left. And then, unfortunately, the strategies, the 4+2 strategy in particular, it was 4 rounds of NID type campaigns everywhere in the country, plus 2 additional rounds in the high-risk states, those 8 high-risk states I mentioned, Rajasthan, Madhya Pradesh, UP, Bihar, West Bengal, Orissa, those, and a couple of others that consisted of the 8 high-risk states. So that was then 4 rounds everywhere, plus the 2 additional rounds in those 8 high-risk states, what we called the 4+2 strategy, and that knocked down transmission. Unfortunately, that's not the time when you let up your guard and back off and say, okay, we can cut back, because this virus over and over again has been shown to reestablish its foothold. And that's exactly what happened in 2002. Lucknow had 1,600 cases of paralyzed children. Anyway, I was available to go back. I was in good cardiac status, and so I spent some 8-9 months back in Uttar Pradesh, working out of the Lucknow office, helping address that outbreak. But, so the point, I'm sorry it took so long, but the point was, there is Dr. Prakash Singh leading the program, leading the charge. And it was one of those things, I always had this little smile every time I saw him, he's the sex therapist. So it's kind of like, anyway.
That's great. Let's see. There's a follow-up question I wanted to ask you about OPV. OPV was supported as the vaccine, and you mentioned earlier a meeting where IPV, I think, was discussed. Wondered if Jacob John was at that meeting.
Oh, you've done your homework.
And I wondered, I've been really lucky to have a lot of help for these interviews. It's great to talk to people. But I wondered about the debate of OPV and IPV at that meeting and at that time.
Yeah. Well, it wasn't limited to one meeting. It was an ongoing point of discussion and debate over a long period of time, actually. So you had, of course, the camp led by Dr. Jacob John, who believed that IPV should be the vaccine of choice. And you had that person in a key leadership position, like Dr. Jatna Soki, who decided that the vaccine would be OPV in her nation. And so Jacob did several studies at the Christian Medical College to try to expand the virtues of IPV. It's a great vaccine, and it's the vaccine we need after eradication, and countries are introducing it. We've been pushing for introduction in Latin America for some time. There's unfortunately a global supply issue, but the commitment from countries is extraordinary to the extent that they are using dose-sparing strategies. They're cutting back on their schedules to make vaccine more available to countries who need it and have yet to introduce. So a lot of dynamics and cooperation to help adjust to limited supplies that I've been told are being freed up now. But yeah, it was. I was in my little packet of overheads. I had one on IPV versus OPV because I was always ready to address the issue. Certainly, OPV, as we know, was a key underguiding element of the PAHO eradication strategy and what became the strategy in Southeast Asia and in Western Pacific, globally. And it's no longer debated now. It's just recognized. We could spend a whole other interview on the circulating vaccine-derived poliovirus issues. And I remember Phil Miner in meetings and global meetings in the early, 90s, if not earlier than that, but always acknowledging the hypothesis, well, what if this OPV virus mutates back to the wild virus form that was the original source of Albert Sabin's vaccine? And what if? Well, everybody poo-pooed that as a hypothesis. Okay, yes, that's an interesting idea, but it's not likely. Well, it turns out we live in a world with outbreaks of circulating vaccine-derived poliovirus now. So that's really why we have to stop using. And for me personally, it's eradication is really about eradicating both viruses because they both cause paralysis, and we're in this to prevent that. That's the target. So just to be focused on wild virus to me is a huge, it's sad for me. But be that as it may, yes, those debates went on, and we discussed them in scientific forums, and I supported the Indian government, and I think to a certain extent that probably undermined the likelihood of developing a more collegial relationship. Dr. Jacob John has made some incredible contributions to the health and well-being and children of India. There's no doubt about it. And unfortunately, we were on different sides of the discussion. But I highly respect him.
Let's see. I just had a fleeting follow-up question there. OPV, IPV. Okay.
Did we talk about the evaluations link? 1998 was what I called the year of the evaluation, because ultimately many of these discussion points would enter the evaluation considerations and issues that the teams who were evaluating would address. Quality of campaigns, for example, using the OPV as the vaccine. So in that year, there were 3 critical evaluations that really helped move the agenda. There was what was called the INCLIN study, led by Dr. Aurora. INCLIN stood for clinical epidemiology, and it was supported by AID for many years. It was an NGO, I think based in Delhi, whose director was Dr. Narendra Arora, who's an excellent public health expert, a gentleman, just a great mind that thinks through critical issues when evaluating public health programs. Because it's challenging. There are a lot of moving targets, and what is it that you're evaluating and measuring, and what will be your conclusions and recommendations. He started a study evaluating the campaigns in India in particular he started those studies in 1997. Took almost more than a year to collect all the information, and he presented his findings that resulted in 1998, in this year. Basically what he found was that, number one, the program had adopted the flexibility to translate the leadership, commitment, and engagement to the local level. That was one, and that was coupled with, secondly, a very effective social mobilization effort that really promoted the activity and engaged local leaders. So those were two messages that we could keep repeating among the partners. There was another, what was called the National and International Review of the Indian Polio Eradication Program that also was done in 1998. So people like Nick Ward and others, a team of some, I want to say 20. It was a sizable team that met, that then dispersed throughout the country to collect information, conduct interviews, come back, compile a report for the ministry. And it was an amazing effort. And the one finding that we used that I thought really helped the program make that final push, or at least take it to another level, was the recognition that the strategies need to be accelerated. So it's 1998, your target is 2000. We understand you mean business. If you mean business, you have to really increase and accelerate your strategies, namely the NIDs. So we could use that to develop the 4+2 strategy with the backing of a technical consultative group. But I really found that that evaluation was really a milestone in the program in empowering the future decisions of acceleration to get to have a fighting chance to get to the target 2000. Then there was a third evaluation, more a political but yet highly useful evaluation. The former director of PAHO, Dr. Carlisle de Macedo, was the regional director of the Pan American Health Organization during the era of Cyril de Quadros. So during that polio eradication era, Dr. Macedo was a champion of polio eradication, which is very important because every regional office has this governance, leadership, political commitment opportunity when they hold their annual regional meetings where all countries send their ministers of health to the meeting. And at that meeting, they receive updates on progress of programs. They provide recommendations. They adopt resolutions. So it's a powerful venue when used correctly. And so having someone of that stature come to Southeast Asia, conduct a review, and then provide to our director the findings was incredibly powerful, because now Dr. Utan, the regional director, he's been supporting, but now he knows, oh, there's no turning back. This is it. We've got to put the pedal to the metal. And the key message that Dr. Macedo left was, you have this window of opportunity to support essential immunization. Whew. We're doing all this work with Bihar, Uttar Pradesh. We're gaining momentum. That was also an important finding. I just now recall that I had asked Dr. Ward, it might have been that year, just to do an internal evaluation of the polio team in the regional office. So he came and interviewed folks in the regional office, also in the NPSP, and did a nice evaluation, more of a management leadership evaluation. What could we do better? We're working our tails off, but what could we do better? And that evaluation was a fourth one that also was very useful in that team setting. How could we be more efficient? So so all that helped sort of set the stage and launch pad for the final 2 or 3 years. And like I say, benefited the need and the choice for the 4+2 strategy, the acceleration of surveillance, and the commitment.
That brings us to 1998, and we are 5 minutes over time. I know that you're on your way to the airport.
Yeah, so we just kind of covered 1998, 1999, perhaps, which now the technical consultative groups were well established. You had the one for India, you had a regional technical consultative group for the region, and chaired by Dr. Prayun, who was the minister. Well, basically, he was the director of control of communicable disease equivalent in Thailand. Recall back in '94, the Thais were the first to do the NIDs, and we had the first technical consultative group meeting at the regional level in Nonthaburi, 1994, to basically put the spotlight on Thailand and credit them for the leadership that they took. But Dr. Prayun remained in the program for many years, and in 1999, that was nice to see. I think that's when I had my health event. But what I recall is the SARC, the synchronization of the campaigns continuing with the same momentum. So you have, you think about China, India, Bangladesh, all the Southeast Asian countries, plus China, during the month of December and January, conducting national immunization days. I mean, we could do the arithmetic. That's a huge proportion of the world's children less than 5 years of age. And
Can
I'm
we
always
pause
struck.
for a moment?
Sure.
Sorry.
So, and that was an amazing, I believe, amazing achievement to get that sort of cross-border coordination and synchronization of the vaccination. What I also remember, a huge part of the work during that year were the cross-border meetings for surveillance and vaccination, but surveillance in particular. So there was a meeting, and we were able to cross WHO regions, because we had a meeting of Pakistan, India, Nepal, Myanmar, and Bangladesh, all sitting at the table talking about cross-border collaboration. I was always struck by, in UP, you have this huge number of cases, but if you just go over the border in Nepal, there are no cases being reported. What's going on? And I almost went to the dark side. Well, if you send somebody to go collect a stool sample, are they just submitting their own and not collecting it from the child? You can imagine the operational challenge, knocking on the door. Well, my child defecated. Well, I changed the diapers an hour ago. She's not going to defecate for, could you come back tonight? And you drove that way, and then so you can just start to picture what a huge challenge, just getting a stool sample. So I started going to the dark side and picturing, well, are they actually collecting, and why is this? But that, the amazing thing in public health is when you show good practice in one locality and you demonstrate it to an adjacent locality, they start to think, we can do that. And it spurs. You need to be able to say that this child you're taking care of in UP actually came from this village in Nepal, and you have to communicate that. And so it established a mechanism of cross-border collaboration and institutionalizing those meetings despite the arbitrary WHO demarcations. We could bring the Pakistanis in and so on, discussing these issues. So that was a lot of work went into that. There was one also with Myanmar and China. You may recall that it might have been in 98, 99, that India had exported a polio case to Hunan, the province of Hunan, China, that created a huge effort and intervention on the Chinese side appropriately by doing a mass campaign to stop transmission. They did an excellent job, but the cost of that, I think at one time we tried to estimate that cost to provide us evidence why you need to stay on top of the cross-border collaboration. But yeah, India had actually exported a case to China that had achieved sort of a polio-free status. So the cross-border collaboration was essential. And I remember that year putting a lot of effort in, and then the synchronization. I always felt, Operation Mechacar was amazing. Europe, Eastern Mediterranean, got a lot of press, but our synchronization, I don't think to this day, very few people know about it.
Why is that? I am more familiar with Mechacar in
Yeah.
the readings.
I don't know why. I don't know why. Maybe I couldn't speculate. I think the global leaders at that time, Bruce Aylward and others, were much more engaged and involved with Mechacar than they were with our efforts. So that's probably. It's interesting when you hold a meeting of consultants, invariably someone is going to talk about their most recent visit as an entry point to their discussion. You see this all the time. Well, when I was last week or a month ago, and then that is, I think that may have been part of human nature. I don't know.
So maybe that direct spotlight,
Yeah,
just the recency.
Exactly. Yeah.
Got it. That is interesting. In terms of scale, do you know if they were comparable? There are many people in China and India
if you
alone.
Put, I think the proportion of the world's population, less than 5 that live in China, India, Bangladesh, right there. Indonesia, it's got to be over half.
I will look into this. I will look into this.
Amazing.
So that brings us up. Does that bring us up to 2000? Does. Okay. And so you mentioned that you left, having experienced a health event.
Yeah. So 2000. It sort of started to realize that I'd have to leave. And planning for that and setting the stage for someone to take over. So I think the target date, I was going to be leaving by June. And so Brent Burkholder, who was my successor, was able to come in advance, and we spent a lot of time together. That is an exception in the case of WHO. Usually in WHO, somebody leaves, and then there's a gap of a year. Dr. Okobele is a prime example. He left, 2 years ago? Now Dr. Kate O'Brien is now the director of the program he led, IVB. It's got to be over a year. And that leaves enormous gaps in leadership, and people struggle, and it's hard to keep the spirit of core. I think Steve Kochi helped me enormously in feeling good about leaving a shop and not having avoiding that gap that was critical. I had been exposed to Cyril de Quadros, and he was so time-bound. Plus, when you make a public statement, you're going to do something, you do it. So the target in the Americas of 1990, when we were 8 months over, there was this balance of elation and not anger. Cyril got angry, but just orneriness that we didn't reach the target. We were 8 months over. So, okay. I believe, Cyril, I'm saying to myself, okay, yes, I also agree. If you're going to say something and commit yourself to it and engage these other people to be a part of it, you better darn well do everything you can. And that's probably why my health started breaking down, because I was so committed to reaching that target. So 1998, regional director, not regional, the, what do you call it? The Director General of WHO, Gro Blundland, came to CRO to give a speech to the staff. I have the document. It's 12 pages, very small type, and in the the lengthy European-style paper. So it's a long speech. In one teeny phrase, embedded in a sentence that takes 3 or 4 lines, it's a run-on sentence, in quotes, to control polio. That's the only message. And I was, if I was more mature, I'd be able to control my emotions and not take it personally. And but I lost sleep over that for many, many nights. I went up to her afterwards, and elevator speech, tried to make the pitch and let her know diplomatically she missed the boat. We only have 2 years left. She came back a year later at a polio meeting and gave this eloquent speech about the need to eradicate polio.
Not control.
Not control. So and to mention it more than once in this whole speech that outlined her vision, the absence of polio being in her vision. So it was very distressful. Who am I working for? Who's helping us? So then she came around, but the eradication clock lost another year. So I think that was, in a way, heartbreaking, incredibly heartbreaking.
One of the themes that has emerged and that I pay attention to anyway, because I'm interested, are working conditions. And, for everyone from community health workers on up, could you talk a little bit about average day and some of the challenges of your working conditions?
Well, what struck me when I first arrived to the building in Southeast Asia regional office. It's in. Gosh, I'm having a senior moment. The name of the street, but it's right next to a slum. I could look out my window down on this slum of just cardboard shacks, no running water, polio. But the office, all the support staff, and 99% of the professional staff were male. There was not. I don't think there was one female secretary, and then you had virtually. There was one woman. I think she was from Sri Lanka, but most were male. So I wanted to change that in my group, and I hired the first female secretary, and recruited women like the virologists who led the network, wherever possible. And it's challenging because you have to keep a certain standard, a bar that of scientific, technical, and operational excellence. That's number one. And then once that bar is met, then you try to build more equity in your workforce, more opportunities. So it was challenging in that sense. But what I remember, when so in '96 I had I had a back injury. I herniated 3 discs in my back. And as I knock on wood, I have not had surgery, but I occasionally have flares. The last one was in Geneva, actually, in August. But I would have to, when I came back after 2 months of physiotherapy in stateside, I came back. I couldn't sit for more than a half hour in a seat without feeling pain. And I had this sort of ongoing gnawing and pain in my back, but it was getting better. My physiotherapist in San Francisco, where I was going to the St. Mary's Spine Center, was a retired UCLA gymnast. She was not retired, but in college she was a UCLA gymnast. So she was excellent. She motivated me. Well, she said, John, buy a Nordic track. So I took that back to India because you have to stabilize your spine. That's how I found out I had heart disease. It was like a treadmill, So later, but anyway, in '96, I'd have to take phone calls lying down, and there were two things that happened at 4:30. This one rat that would go running down the hallway. It was clockwork. I could see this rat in our building, public health building of the region, of the health house of the region. And the other thing that happened at 4:30 was Mr. Bharwaj, who was one of this male network, who was partially blind due to his out-of-control diabetes. And under his desk was this mass of garbage because he couldn't see the garbage can. He would miss it. And that's probably why the rat was going in that direction. So I didn't put it together at the time. but anyway, so he had an alarm clock that was voice-driven. It would ring, and then it would say, "Wake up, Mr. Bharwaj. It's time to go home." So anyway, so this is kind of the circumstances that were challenging, to say the least, and to basically use the opportunity to create equity. And by the time I left, I think we had several women on the team and staff. And you go back to Southeast Asia now, you see a lot. It's changed, and I feel proud that I was kind of a catalytic in that.
I don't know whether this connects or not. Excuse me, but someone donated a mug to our project, and it's called LIPS, and LIPS is an acronym. I think it's Ladies in Polio, something S. Are you familiar with this at all? Ellen Ogden was someone who was on the mug.
I heard something. I don't remember the word LIPS, but I seem to remember that there was a group that had been established. That sounds good. It's a nice network.
Yeah.
Ellen helped that whole effort that went into BIMA and UPALA and all those field trips there and meetings and site visits. Whenever she was in town, she would go with us, and she was very committed to that too, and was very helpful. So yeah, she's been in the program since the beginning.
Long time. Yeah. There was a connection to leadership as well. Maybe the women pictured on this mug were the women who were in leadership positions.
Yeah.
And polio. Let's see. So we're starting to wind down because I don't want to make you late to the airport for sure. Is anything jumping out in your mind that we have not covered today up to about 2000?
I've known for a couple of weeks that I would be coming here to interview with you, and I've sort of attempted to collect my thoughts, and it brings back a flood of memories, at times very emotional. A couple of weeks, recently, not this last Sunday, but I think the Sunday before, do you know Jacques Pepin? There was Julia Child's friend.
Yes, the chef, yeah.
Yeah. I used to love Julia Child. It was one television program I loved to watch, particularly when the two of them would team up, and I love to cook. So he writes this editorial in the Washington Post. The title, it was a catchy title, but it had to do with eggs, the case for eggs. And he's an amazing writer, because in this editorial, maybe a third of the page or half the page is this letter, and he describes the value and the emotional influence eggs have had in his life. Reminiscing when he was a small boy, tasked to be in charge of the hens and having to negotiate that aggressive hen that would always try to keep him from grabbing the egg and collecting them. So he tells it very articulately, and then he goes over the science. Some 20 years ago, scientists were saying 1 egg a week, and then how that kind of swung a little bit. And he cites his family. You beware of the one case, because he cites how long his mother lives and how many eggs a day she ate and how much. But there's a scene where he cracks the egg, and he says, as the yolk and the white floods onto the pan, a flood of memories comes in these childhood memories. So what I'm trying to say is that I think in the last couple of weeks, it's been a wonderful opportunity to reflect. One thing that comes away is this whole, the friendships. Because when you've been through things together and you have this collegiality that extends into a lasting friendship, it's incredible, it's amazing. And as I grow older, you read about longevity. What are the factors you can control to promote longevity? And you want to avoid isolation. You need friendships. And I'm blessed because of that. And it makes me, in a way, emotional. Yesterday, I heard a talk here at the CDC on surveillance in Africa. Jason Mwenda of Afro gave an excellent overview on the work being done in Africa on comprehensive vaccine preventable disease surveillance. And then I reflected on Mac Otten and his role in helping develop surveillance. And then I thought, I haven't heard from Mac in years. I wonder what he's doing. What's going on? And because I had so much fun visiting Afro. And after India, Okabelli asked me to go to Africa, the Afro office in 2000 to evaluate their comprehensive surveillance program. They sent me to Malawi. I got to visit my old Peace Corps village. It was just a very fun, exciting experience. And when I was, at that time, the Afro office was in Harare. It's a beautiful city. And had a couple of dinners over at Mac's house. And I don't know if I should say this, but, we work our tails off. And Max likes to golf. So he and I went golfing one afternoon. We worked that night and whatever. Anyway, Steve Kachi calls us while we're golfing. so caught. Oh, but so I fired off an email. Fortunately, when I went to the email and the to line, I put Otten and his address popped up, the Gmail or whatever it was. So I fortunately had that, and I shot him, how are you doing, man? And then I got this wonderful message back, and it reminded me of those kinds of experiences. You've been through these battles, and you develop. I connected with Kaushik. I always can text him a joke that he'll laugh at, and you just in Paho, Linda Wenzel, who then went on to be a polio advisor for Bill Gates and accompany him to various countries. And she comes and actually lectures at my global vaccinology course. And the PAHO colleagues like Lucia Oliveira, Desiree Pastor, and others. There's a shrinking network of folks that got exposed to Cyril Quadras' leadership, and with that, I'm sort of compelled to keep in touch, and it's a lot of fun reminiscing. But they're still there, providing great leadership and amazing contribution to public health. So I think that, to answer your question, it's those kinds of things that you didn't expect at the time, but now that you get older and you're doing everything you can to live as long as you can, And when one of them is have friendships, oh, that's a no-brainer. Anyway, not to oversimplify.
No, that's great. I'm looking over my list. How about lessons learned up until this point? We've covered a lot of that too, but is there anything lingering?
So, you often get asked that question, and I think I appreciated Tom Frieden's response to that question, which you can do the elevator speech or you can go on and on. Sometimes when I get excited about something, I may talk too long. But I think Tom's response is excellent. Leadership with political commitment and financing that's necessary, along with excellence in technical expertise and operational expertise. And those are themes I think I've come back to throughout this conversation. So I think very succinctly, that's the key lesson, those lessons. I'm concerned now about leadership globally and being able to take us over the finish line. We're some 19 years past the target, and so we as we engage and continue, eventually there's that risk of becoming part of the problem. That's pretty somber.
We also just hit the 5-year anniversary of certification, right? March
Yes.
27th of
Yes.
2014
Yeah.
was the date of certification.
That was so being invited to go back, I think, pulled me out of my shell, because when I left India, I sort of, with the exception of 2002, going back to Uttar Pradesh with the outbreak, I made a concerted effort to not be engaged. I'd had enough. I'd been asked by PAHO to lead the immunization program there, so I could focus on other things: measles and rubella elimination, the introduction of new vaccines, and then eventually I was fortunate to be asked to be the PAHO deputy director. So that kept me busy, engaged, excited to get up every day and go to work. So I didn't have to think about global polio eradication and whether or not we're going to cross the line. But then, having been invited to the Certification Commission and seeing the document and the old friends and colleagues, I thought, gosh, this is amazing. And so when I was approached by Ambassador John Lang to be co-chair of the Polio Partners Group, I said, gosh, maybe this is one way to get back on the playing field in a different capacity. Maybe I could help, who knows. But that's why John was able to convince me, and that's what I do now. And I have other responsibilities that are nice. Being focused just on polio, I think, can be wearing. But when you have, when you're positioned to be able to deal with a broader base of immunization objectives, I think that's more exciting for me. So having a little bit of that, and then being on the PAHO Technical Advisory Group, I'm now the chair of the PAHO Measles Rubella Elimination Regional Monitoring Commission. So it's a commission that evaluates the sustainability of measles rubella elimination in the Americas. So that's exciting work. And I have that link to Southeast Asia, being on their verification commission too for measles and rubella. So we're going back to Nepal next week, actually. And I'll be there 5 weeks doing a national evaluation and then having the regional commission meet. So yeah, I'm very fortunate.
Last question on the occasion of the 5th anniversary of CRO being free of polio. Yeah. Can you mine your memory, take a moment to mine your memory for objects or images that come to mind in addition to what things you've already mentioned?
Well, with me, what you see is what you get. So I'm very literal. So when you said object, I immediately went to the statue of an Indian goddess that I have in my office at home that Dr. Harshvardhan gave me when I left India in 2000. And it says on the plaque to Dr. Andrus, may you have all the blessings that the good life has to offer, something like that. And I see that every day, and again, I think of my admiration and respect I have for him as a person, and having had that experience, just how lucky we all are. I have my 5th grade best friend works as a tax consultant in Long Beach, California. Now, he has a wonderful family, wonderful life, but that's what he does. And we see each other a couple of times a year. We went to the Giants spring training in Scottsdale. And, sometimes I want, I couldn't do that. It's been nice. It's been a real nice, there's so many things you take away from it. You try to give, but you take more than you give, actually. So that was when you said object, that flashed there. But yeah.
Yeah, that's great. Anything else Laura Frizzell, the archivist, who you've met, she's accepting donations and soliciting donations from people. So I asked this question to give us a sense of the visual landscape of the program.
Yeah. Do you have the polio volunteer, the Tommy Francis pins?
I don't think so.
I was a volunteer in that clinical trial of the Salk vaccine. I was invited to the University of Michigan 4 or 5 years ago to I think it would have been the 50th anniversary of that study, which is a field trial of unprecedented size and has never been, in terms of size, it's the largest of its kind. If you think of a multi-site, multi-state national clinical trial, pre-computer of the Ipv when Salk came out with the vaccine, and the press conference that announced it, the results of the Tommy Francis clinical trials. This was one of the segments I teach in my class, reviewing, to think that it was mostly done by some 300,000 volunteers and the data entry all by hand. So anyway, when I went to that event, they had these the pins. Now, I can't remember. What I do remember is taking my sister to be vaccinated, but that was with the Sabin vaccine, which they at that time put on a sugar cube. And it was San Lorenzo Elementary School in King City, California. I remember that event, but I don't remember a pin but apparently all the children that participated in this trial, their parents didn't know if they were going to get the placebo or the vaccine. And the results were phenomenal. I think the first words that came out of it was, if it was Dr. Francis, as I recall, the vaccine is safe and effective. And, it's just, I think the church bell started ringing this very quickly. So those pins, I think I have, I would like to keep one for my own self, but if I have more than one, that was one thing that came to mind. There are a number of T-shirts, coffee cups. I remember the Bangladesh has a coffee cup that's I have a couple, but that's hard to.
Even a photo.
Okay.
Even a photo, or just
Yeah.
so it's helpful to have.
I sent you some.
Great.
Yeah.
Okay. Good.
Yeah.
I'll check in with Laura and we'll
Yeah.
see. We try to pair the excerpts from the oral histories
Yeah.
with images of artifacts.
Well, there's this amazing photo I have of the Delhi campaign, where the grandmother is holding her granddaughter, and she has paralysis. You can see the asymmetry of the musculature of the legs. You know, the child is afflicted, and the grandmother is got terrible scarring of her face. She's a smallpox victim.
Wow.
And I was able to take that photograph, and it's a visual. Unfortunately, she didn't make the connection with prevention, and now has a granddaughter that's paralyzed. And we as public health practitioners failed to empower her with that connection. In a way, it was in a slum area, and the conditions are very poor, but it's a sad message that the child unnecessarily contracts polio.
But perhaps strong motivation.
Yeah. Well, the last case in Peru, August 23rd, 1991, Louis Fermin became part of the measles rubella vaccination campaign. He was a vaccinator in the national campaign to eliminate measles rubella. That's a wonderful story. But unlike the grandmother and the child, yeah. Yeah, I have that photo at home.
Any final thoughts for today?
No, I had fun, and I appreciate the opportunity.
Thank you.
Thank you. Let me know if there's anything I can do to help.